Good day, everyone. Welcome to ACMQ's educational webinar sponsored by our Education Committee. Today's webinar is titled MACRA, an overview with Arnold DoRosario, MD. My name is Angelica, your coordinator here at ACMQ. Before I turn the program over to Dr. DoRosario, I would like to review a few housekeeping FYIs. Today's complimentary webinar is being recorded, and all registrants will receive the webinar archive in a follow-up email later today. The email will also contain a link to a short survey. Please be sure to complete this evaluation, as your feedback is very important to the Education Committee in creating new programs such as this. For the duration of the live presentation, all participant lines will be muted. There will be an audience question and answer period towards the end of today's presentation. If you do have any questions for Dr. DoRosario throughout the session, please feel free to type them into the question pod, which is located in your attendee control pane. Usually it's along the right side of your screen. And if you have any technical issues during the session, please type them into the chat box or the question box, or feel free to email me at atom@acmq.org. That is atom@acmq.org. Now, it is my pleasure to introduce our presenter, Arnold DoRosario, MD. Dr. DoRosario is Vice President, Chief Medical Officer, and the Chief Population Health Officer at the Northeast Medical Group, Yale New Haven Health. He's also an Assistant Clinical Professor at the Yale School of Medicine. Since 2014, he has been the Vice President, Chief CMO, and Chief Population Health Officer there. He is the chairman of the NEMG ACO Board of Managers, NEMG Medical Director Leadership Council, and the Credentialing Committee. He is on the Senior Management Committee, their Epic Performance and Utilization Committee, Steering Committee, the Implementation Steering Committee, and the Advanced Care Planning Committee. He also co-chairs the NEMG Quality Improvement Committee. He's a very busy man, as you can tell. So Dr. Rosario also serves on the McKesson Technology Solutions Advisory Board and the Anthem Patient-Centered Primary Care Program. Prior to joining the Northeast Medical Group, Dr. DoRosario was a founding member of PriMed, a 120 provider multi-specialty group, and he served as medical director and focused on implementing policies, procedures, and best practices among the group. In 2012, PriMed was one of 15 physician groups nationwide to receive the designation of prepayment ACO. He has been practicing internal medicine and geriatrics in Fairfield County, Connecticut for more than 35 years. Dr. DoRosario received his medical degree from the, excuse me for mispronouncing this in advance, Universidad de Navarra, Facultad de Medicina in Pamplona, Spain. I apologize to all Spanish language speakers for my horrendous pronunciation there. And he is board certified in both geriatrics and internal medicine. He completed his residency and internship at St. Vincent's Medical Center of Bridgeport. Dr. DoRosario will also be speaking on payment reform, practical implications in the ambulatory setting at ACMQ's own 2017 annual meeting. Later in March, you can view the full program and learn more about the Medical Quality 2017 annual meeting at acmq.org. Now, it is my pleasure to turn it over.
So this is the trajectory we've been on, as we are all familiar with. We are at a point where we started shared savings and ACO in 2012. Risk-bearing later on, and now we've come to MACRA. One of the reasons that MACRA was introduced is because CMS had a goal in mind to have at least 30% fee-for-service, and 30% value-based and the rest fee-for-service, and to hit a target of 50% value-based and fee-for-service by 2018. In 2016, they did attain their goal in the first quarter, but clearly what they did recognize was that despite the fact that ACOs were introduced in 2012, there were several tracks you could follow. Suffice it to know that track 1, which is the most popular, is upside risk only. Track 2 is upside and downside risk. Track 3 is downside risk and upside risk, and Pioneer Next Gen. But despite the forecast, what happened over the last few years was that there was an increase in track 1 upside risk only, and the downside risk ACOs did not gain any traction, and hence MACRA. So MACRA is the Medicare Access Chip Reauthorization Act of 2015, and there are two pathways, which is mandatory in fee-for-service Medicare. ACO was an option. You could enroll in an ACO and choose the track you wanted to be in. MACRA is not an option. It's a mandate. You have two pathways to follow in MACRA. One is a merit-based incentive payment system, and the other one is an advanced alternate payment model, APMs. A subset was created, and we'll address this later, of MIPS APM. I apologize for the confusing acronyms, but it's really important to get an understanding of this. So we have a MIPS system, an APM, and a MIPS APM. The major difference between those two is in the MIPS APM, or the MIPS Merit-Based Incentive Program, will receive a positive or negative adjustment based on performance for categories, and we'll address these categories. There's 2-year lag between the performance measurement and the payment adjustment. 2019 based on 2017. So 2017 is the performance year, and the payment will be 2019. In the MIPS system, we also have high performers who attain additional points, and there'll be an additional bonus that's paid out between 2019 and 2024. In the APM, which is the alternate payment system, also called the advanced alternate payment system, there are certainly stronger financial incentives, higher annual updates, several-year guarantee, but the key qualifying criteria to follow the APM is that you have to be in a program that has financial risk, and we'll address that. So that's the major difference. The next important thing to remember is that this is fairly fluid, and over the last year, they've made multiple adjustments from all the feedback they received, which was a good thing. So we know that the 4 buckets are going to be quality, cost, advancing care information, and improvement activities, and we'll discuss this. But for the year 2017, what they've done is they've removed the cost factor. And suffice it to know that as time goes on, the weighting of these categories will change. And the reason for that is for us to all overcome the learning curve. So the important thing is that there are 4 categories. In the first year, the cost category, also called the resource, is 0%, and the other percentages are redistributed. And over time, some of this weighting will continue. So the MIPS APM is a special category, particularly in networks, that are in track 1 ACO upside only, and there is some advantage of doing that. So there's just quality, advancing care information, and improvement activities. So let's just go over this again in the incentive payment system in the MIPS. In the measure performance, you have a 2-year look back, which we alluded to. Performance 2017, but adjustments in 2019. There are 4 weighted categories that we addressed: quality, cost, advancing care information, and improvement activities. Some of the components we have in place now, which is EHR meaningful use, PQRS, and value-based modifier, will sunset in 2018, and these measures will be incorporated into the MIPS category. With respect to the scoring, participants will receive an annual final score between 0 and 100. Score will be publicly available via physician compare. What is the threshold? Each clinician score compared against a performance threshold to determine payment adjustments. And this is to be determined yet. Beginning in 2019, the performance threshold will be based on the median of MIPS scores, and we'll know this ahead of time. And you can have additional adjustments, remembering that this is a budget-neutral program. So let's talk about some examples of the buckets. Number one is the quality performance category, which the weight will change from 50% to 30% over time. So most of the quality categories is something we already do. Example is care coordination. They're going to look at readmissions, transition care management, seamless care among health professionals, team care, patients, caregivers, and families, patient and caregiver-centered experience. A lot of us engage in PRESCANI. This is patient and caregiver engagement, individual and population level data. Community and population health, preventive services, improve population health, effective clinical care, evidence-based medicine, following clinical practice guidelines. These are a lot of the quality metrics, for example, we use in diabetes. Patient safety, process to reduce risk, diagnostic accuracy, medication errors, measure the occurrence of adverse events, complications, and interventions. This is the other category that we call improvement activities. Again, the clinician and groups choose from 90+ activities in the following categories. So you have a choice. And here are some examples as defined in legislation. Expanded practice access. Most networks are now having extended hours. Population management, we use doing outreach, for example. Care coordination. Beneficiary engagement. Having a representative of our patient population on committees. Patient safety and practice assessment. And then participation in advanced payment model, including medical homes. Additional proposed domains for achieving health equity, emergency preparedness and response, and integrated behavioral health and mental health. And one important comment here is that if you are an accredited medical home or you participate in any form of an ACO, you get full credit for this category. The next category is advanced care information. This is what we refer to as meaningful use. The overview is there's a base score, and the base score is primarily, you get the base score by yes, no, on a numerator-denominator measure that you must meet at the first pass, and the performance score, and we'll see some examples for this. The important thing to remember is there's 155 total points. You only need 100 for a maximum score. So what's the base score, for example? To receive a base score, which you must comply with to go to the next step, clinicians must provide numerator, denominator, or yes, no for each measure. Do you do this or you don't? Protective health, patient health information. I'm sure we all have security systems in place to prevent breaches. Electronic prescribing, which has been pretty standard. Patient electronic access, for example, MyChart, if you're an Epic. Patient engagement, health information exchange, and public health clinical data registry reporting. And you need to achieve a base score in order to receive a score in this category. Performance score will be larger categories, as we'll see on the next slide, which are patient electronic access, coordination of care through patient engagement, health exchange. Here's an example of some of those, which are in patient electronic access. It's again MyChart, patient-specific education, coordination of care through patient engagement. That's what the care coordinators do. Secure messaging. With the health information exchange is send summary of care. After visit summary, for example, request and accept summary of care when we exchange with our specialist or the hospital. And if you belong to an immunization registry. And these are, again, some examples of what meaningful use will be replaced by. So again, what is the scoring? You get full, for the base score, in advancing care information category. You get a full credit for answering yes and submitting numerators greater than 1 for each measure under the 5 objectives. Clinicians or groups not meeting submission criteria for any measure in the base score will receive a category score of 0. Again, you can't go to the next stage unless you get some score. And this has a potential of 50 points. In the performance score, clinicians and groups receive 1 to 10 points for each of the 8 measures based on their performance rate above the base score. And clinicians and groups receive 10 points for reporting to an immunization registry. The total potential points here are 90. And then you have 15 bonus points. But you need to only attain 100 points to get maximum score. I know this part sounds a little confusing, but it is not a difficult metric to meet. It's probably one of the easiest because we do most of this. And the next category is cost. Remember, we talked about 4 categories. The last category is cost, or it's also referred to as resource. This domain has been eliminated for 2017 due to attribution and scoring differences from clinicians and groups, but clinicians and groups will still receive feedback. There has been a lot of debate about this. The final rule went into place in November of 2016, and they made a lot of adjustments, and this was one of the biggest adjustments, is to remove this category completely. For many reasons, the providers were not prepared, neither were they. The cost measures will finalize as proposed, but the CMS will continue to develop new care episode, patient condition, and patient relationship codes to be included in claims beginning or after 1/1/2018, so not even this year, next year. List of patient relationship codes will be posted by April of 2017, and list of codes for care episodes and patient condition will be posted by 12/2017. New codes will likely not immediately factor into cost in 2018. So the important thing to remember here is that this is a very fluid metric that's being developed. They're not projecting this to be in play till 2018. And I'll just give you some examples of how this is going to differ in what we do right now. So the cost measures, the measures include total per capita cost, Part A and Part B, for all attributed beneficiaries. And Medicare spending per beneficiary and episode-based measures. CMS has finalized 10 of the proposed 41 episode-based measures, so they still have to finalize another 31. And the episode-based measures examples are mastectomy, aortic and mitral valve surgery, coronary artery bypass, hip femur fracture or dislocation treatment, inpatient-based, colonoscopy and biopsy, transurethral resection of the prostate for benign prostatic hyperplasia, lens and cataract procedures, hip replacement or repair, knee arthroplasty and cholecystectomy, and common duct exploration. So they finalized 10 of the proposed 41 episodes. Again, the cost, the measures will include total per capita cost, Part A and Part B, and Medicare spending per beneficiary, what is spent per total. So we look at some further explanation on this measure. So the resource use is also referred to as the cost category, and the weighting will change over time. It's 0% for 2017. So this is an improvement what exists currently. Currently, will be an improvement on the current value modifier, which uses 6 measures. We look at total per capita cost for all attributed beneficiaries. We look at Medicare spending per beneficiary, total per capita cost for all attributed beneficiaries, and right now we have condition-specific COPD, CHF, CAT, and diabetes. Once we move into the resource category under MACRA, this will be more simplified, and that'll be 2 out of 6 measures. Total per capita costs and Medicare spending per beneficiary. So this is an improvement about what we're doing right now. And the episode-based measures will be in play rather than condition-specific, which actually allows a broader capture. So with respect to resource use, a cost category, once again, to summarize, it goes from 0% eventually to 30% weighting, but there will be some changes which are quite frankly to our benefit and simplified. So what's the MACRA physician payment timeline? I don't want you to get too involved in this. Looks complicated. Bottom line is, if you look at the green bar, you know, there's over time there's a plus 4%, can go up to plus 9% in the MIPS-based. And with the APM, the major difference is that you have a 5% bonus if you're in the APM APM category, and that's a lump sum payment, and we'll get back to that. So who are eligible to be in the MIPS? That's the first pathway. In the first 2 years, it will be physicians, MD, DO, DDS, DMD, DPM, OT, and DC. PAs, NPs, clinical nurse specialists. After 2 years, the plan is to include physical and occupational therapists, speech language pathologists, audiologists, nurse, in other words, other healthcare professionals. There are also some ways to be excluded from MIPS participation. Remember, we said MACRA was not an option, it was a mandate. But if you fall below the low volume threshold, and they have those limits, if you're in the first year of Medicare Part B participation, or if you're already in an advanced APM, you can be excluded. The reporting options, and I'll probably move to this a little faster because of some time constraints. The reporting options can be individual, group, or through an APM entity. And suffice it to say that those who are in ACOs, for example, report through a web interface to GPro, but you will have options to report as an individual if you're not in a large network. You will have the opportunity to report as a group defined by tax identification number, and will be assessed as a group across all 4 performances. MIPS APM, this is the subcategory we referred to. Remember, in MACRA there's MIPS and APM, and then there's a subcategory called MIPS APM. This concession was made because there was a lot of feedback in large networks and physicians who were in Track 1 ACO, that's upside risk only. They did believe that it did contain some risk, financial risk, to set up the infrastructure, so they created a subset which has favorable scoring for all networks and physicians in Track 1 ACO, which is upside risk only. And that's basically the MIPS APM favorable scoring, because as far as the reporting goes, if you report to the ACO, that will suffice and comply with the reporting. There's no cost use, and for the category of clinical practice improvement activity, you get full credit. So with that category, the reporting is done through the ACO. You continue to participate in the ACO. You get full credit for the practice improvement activities by the mere fact that you're an ACO. And so basically you'll have to comply with the meaningful use or advancing care information. So there was concession made here. It is the belief that most MIPS will eventually advance to APMs, and we're going to talk about that now. How do you go from, if you start with MIPS, which is going to be the vast majority, how do you go to the next pathway, which is advanced payment model? So for the next pathway of advanced payment model, you have some criteria. You have to be in a qualifying model. The quality measures are comparable to MIPS. You have to have a certified EHR. And as we alluded to in the second or third slide, there has to be some nominal risk or expanded home. We're going to look at this. So you have to meet this criteria to qualify for an advanced APM. That means you have to be in a model that qualifies. You have to have the measures, certified EHR, and then financial risk. So these are the categories that are eligible. If you are in a shared savings program or ACO Track 2, not Track 1. Track 2 is downside risk as well. Track 3 is downside risk as well. So it's a next-gen ACO. And then there are other groups. If you participate in a CPC Plus program, if you participate in the oncology care model two-sided risk arrangements, if you participate in the comprehensive ESRD care program, and then some mandatory bundle payments. Most of you will know if you participate in this, then you will have met the first criteria for participating to an APM. Because of a lot of pushback from a lot of practitioners, they also, CMS at the 11th hour, created a pick your pace for 2017. In other words, if you did not participate in MIPS, you would have the potential of losing 4% in 2019. So they softened the blow by saying you have an option to test the quality program by submitting some data and to avoid the penalties. In other words, you will not have an upside impact, but you will avoid a downside impact by submitting some data. And this means, and we'll come to that, submitting just one category will give you 3 points, and you will avoid the penalty. Or you could participate for part of the year, or you could participate for all of 2017, or you could join an advanced APM. So they gave you some options, but the major reason to have this option was to give all practitioners an opportunity to avoid any penalty by doing the minimal, which is submitting some data which is translated in reporting on one quality metric. What's the payment proposal? You can see in summary for the MIPS in the third column is plus or minus 4%, plus or minus 5% the following years to plus or minus 7% beyond. Whether that will be a projection that will come to fruition, it's hard to say with all the changes going on. In the advanced alternative payment model, the major difference is that you are guaranteed a 5% bonus each year. But once again, there's a lot fewer folks who will be eligible for the advanced payment in the initial years. So this is the range of payment adjustments. This is a budget neutral program. So if you look at $199 million, up and down. The scoring is from 0 to 100. The final concession made in November was that if you had a score of 3 points, if you look in the left column, 3 points, you have an adjustment of 0. So by submitting a minimum number, one quality metric, you avoid all the penalty. And obviously, if you get 70 points or beyond, you'll have a positive MIPS payment and additional bonus. But remember, this is a budget neutral program. So by watering down some of the requirements, there will be less losers and hence less winners. But I think it was the fair thing to do in the first year for all physicians to be able to participate and not be penalized. Finally, I want to go through a new program that is coming in 2018, which is related to MACRA, which is an ACO Track 1 model. So remember, we talked about an ACO Track 1 being upside risk only. CMS had hoped they would gain traction with participation in track 1, in upside and downside risk, which is track 2, track 3, and next gen. That hasn't happened. So a new program will be introduced in 2018. It will be similar to track 1, 50% of shared savings, but there's a much lower downside risk. There's a cap on the downside risk. It's 8% of your fee-for-service revenue, or 4% of the ACO's updated benchmark. The other major difference is that in the current Track 1 ACO, you have retrospective beneficiary assignment, which means you really don't know who your patients are ahead of time. They get assigned to you because you have provided more than 2 services to them. And you're also responsible for the cost. That's not under your control from practitioners, not within your network. The prospective beneficiary assignment is a major benefit. We can do population health and outreach and make sure that we close the gaps in care with our patients. It also has an option to elect a skilled nursing facility 3-day waiver rule, which means we can have them go directly into the nursing home in case they need intermediate care. And those currently in Track 1 are eligible, and the date of initiation will be 2018. And this will qualify as an advanced APM. And the reason I make this statement is because I think it's really important, and it is the objective that even though we start on the track, the MIPS track, it is the hope that most networks will advance eventually to an advanced APM by taking risk. And I'll be glad to take any questions at this point. I know that most of you busy practices and need to go back to practice, so I did tell Angelica I would try to be sensitive to that.
Well, thank you, Dr. Rosario. Really appreciate it. Yes, let's begin our question and answer period, audience. Feel free to ask your questions in the questions pod of your control panel on your screen. Let's see. Yes, Dr. DoRosario, we have a question that is definitely on everyone's mind. Will the new administration make changes in MACRA?
Well, I'm sure that most people have an obvious answer. It's really hard to know. But we were in Washington, and first of all, I want to give credit to the Academy, whose slides they've asked me, they allowed me to use today. It's where I got most of my education. And we were at a meeting in Washington in December, just trying to figure out what was going to happen. And there were some folks, some political appointees from the Hill there. I think it's very clear that some of the innovation from the ACO, such as even Track 1 ACO since 2012, have not only improved quality, but has saved Medicare money. And hence, because of that, it'll be very unlikely that MACRA is going to go away. MACRA might get modified. It's hard to say whether the projected pathway of payment and adjustments will continue, but it will remain in some form.
Thank you. Our next question from the audience is, will most MIPS participants migrate to advanced APMs?
I'm sorry, I didn't hear that.
Will MIPS participants migrate to advanced APMs?
That is the hope, and I think, as I mentioned, is one of the options will be a Track 1 Plus, which is being introduced, for example, is to help facilitate the migration from MIPS to APM. And there is a pathway. I didn't go into the details of partial pathways as well, but definitely the plan is for most folks to initiate in the MIPS pathway and go to the advanced APM.
Thank you. Dr. DoRosario, a couple of our audience attendees, I don't know if this is standard along what they've been familiar with, but they've noted for the MIPS category weights, two in our audience thought 60% was for quality, 15% improvement activities, and 25% advancing care information. Could you kind of reconcile where the differences might be?
Let me just go back. So one of the things has been is in the performance year for 2017, the categories go from 60% quality, 25% advancing care information, and 15% improvement activities. This over time is going to change, and then in 2018 we projected some of the changes from the quality going down to 50% and an adjustment made for cost of 10%.
Thank you. Okay. I think so. Hopefully it does for the audience. And audience, if you have other questions that you would like to ask offline and don't feel like you want to do it right here on the webinar, feel free to email them to me and I'll pass them on to Dr. DoRosario. My email address again is atom, ATOM, @acmq.org. We do have another question right now. When will further details be published on Track 1 plus ACOs?
So Track 1, there's a meeting in April, so we think we'll have further details. But if it follows what we've seen with MACRA, we did not have the final ruling till November of 2016. So there were changes made in MACRA in April, then in June, and finally the period to get the final ruling was November. So I do believe that hopefully after the middle of the year, I think given the new administration, there might be some delays in finalizing what's been proposed.
Very good. I think that that was our final question, Dr. DoRosario. Thank you for a very just well outlined presentation. I think you've answered so many questions. And I thank you, audience, for joining us today for the presentation, MACRA and an overview with Arnold DoRosario. If you do have any other questions that you want to ask offline, again, feel free to email them to me at atom@acmq.org, and I'll be happy to forward them along to Doctor, within the next business day. But probably later today. A survey along with a recording to today's presentation will be sent to you. We would very much appreciate your feedback on this short survey. Please be sure to visit ACMQ's website, acmq.org, for future announcements about our upcoming webinars, as well as for details about our 2017 annual meeting, which Dr. DoRosario will be one of our presenters. We very much look forward to that. So on behalf of the ACMQ Education Committee, thank you again for joining us for today's program, MACRA and Overview. Have a great rest of the day. You may now disconnect, audience. Thank you.
Thank you.